Hello everyone. So the day 17 of discussing important perio tables today we will discuss in this video, and the topic is acute versus chronic gingival infections. So gingival infections can broadly be classified into acute and chronic forms based on their onset, duration, clinical presentation and tissue response. Acute gingival infections are characterized by sudden onset, severe pain, and rapid tissue destruction, whereas chronic gingival infections show slow progression with milder symptoms. So this slide highlights two important aspects. Number one is color changes and distribution in various gingival infections. Number two is stages of necrotizing gingival lesions. So first we will discuss color changes and distribution. Let's talk about acute necrotizing ulcerative gingivitis or ANUG. In ANUG, the inflammation predominantly involves the marginal gingiva and interdental papillae. Clinically, the gingiva appears erythematous, covered with grayish-white pseudomembrane. It shows punched out interdental papillae. The localization to the marginal gingiva is due to plaque accumulation and anaerobic bacterial proliferation, especially fusiform bacilli and spirochetes. This condition is commonly associated with stress, smoking, immunosuppression, and poor oral hygiene. Next, we'll move to herpetic gingivitis. Primary herpetic gingivitis is caused by herpes simplex virus type 1. HSV1. Unlike ANUG, the gingival involvement is diffuse, affecting marginal gingiva, attached gingiva, often extending to oral mucosa. Clinically, the gingiva appears bright red, edematous, and bleeds easily. This diffuse distribution occurs because the viral infection spreads through epithelial cells, not limited to plaque retentive areas. Next, we'll talk about chemical irritation. Chemical gingivitis results from exposure to aspirin burns, dental materials, herbal or home remedies. The gingival involvement may be patch-like. Patch-like will be localized contact, or diffused. Diffused may be due to widespread exposure. The color varies from red to white necrotic areas depending on the severity and duration of chemical injury. Now, next is chronic gingivitis. What do we see in chronic gingivitis? We see red or bluish red discoloration confined mainly to the marginal gingiva. The bluish hue is due to venous stasis, reduced oxygenation, and long-standing inflammation. Unlike acute lesions, pain is usually absent or minimal and the progression is slow. So this is the differentiating feature of acute and chronic gingivitis. Now, next part of the slide will be stages of necrotizing gingival lesions. Necrotizing periodontal diseases progress in a sequential manner described in stages based on the extent of tissue necrosis. So the 7 stages were given by Horning and Cohen. Stage 1 is necrosing of tip of interdental papilla, which is 93%. This is the most common presentation. Only the tip of interdental papilla is affected, producing punched out appearance, severe pain, and spontaneous bleeding. Stage 2 is necrosis of entire papilla, that is 19%. The necrosis spreads to involve the entire. So next is stages of necrotizing gingival lesions. Necrotizing periodontal disease progress in a sequential manner described in stages based on the extent of tissue necrosis. So these were given by Horning and Cohen. Stage 1 is necrosis of tip of interdental papilla. This is the most common presentation. Only the tip of interdental papilla is affected, producing punched out appearance, severe pain, and spontaneous bleeding. Stage 2 is necrosis of entire papilla. The necrosis spreads to involve the entire interdental papilla. At this stage, tissue destruction is deeper, pseudomembrane formation is more evident. Then stage 3 will be necrosis extending to gingival margin. Okay, so necrosis progresses beyond the papilla to involve the marginal gingiva. This leads to loss of gingival contour, increased halitosis, and severe inflammatory response. The next stage is necrosis extending to attached gingiva. In rare cases, necrosis spreads apically into the attached gingiva. This stage indicates severe disease, compromised host resistance. Stage 5 will be necrosis extending to buccal or labial mucosa. This disease extends beyond gingiva into the oral mucosa, indicating progression toward necrotizing stomatitis. This stage is often associated with malnutrition, systemic illness, or immunodeficiency. Next stage is sixth stage, which is necrosis exposing alveolar bone. Here, soft tissue destruction exposes the alveolar bone, leading to severe pain, risk of secondary infection, and rapid periodontal breakdown. Stage 7 is necrosis perforating skin of cheek. This is an extreme and rare stage, historically associated with noma or cancrum oris. It occurs primarily in severe malnourished individuals and immunocompromised patients. So, conclusion is necrotizing gingival disease represent a spectrum beginning as localized papillary necrosis and potentially progressing to devastating facial tissue destruction if untreated. Early diagnosis and management are crucial to prevent progression. Thank you.